Okay.
Still parallel,
So I'm Jay Patel. Wanted to give this talk on vent waveforms, mostly because I had no clue what vent waveforms meant, and after getting a few lectures, I still was curious, so I looked into it, and I started drawing them out, and I thought maybe I should share this with everyone. So this is not going to be a talk on basic modes of ventilation. It's going to be more of like what you see on the ventilator and how to interpret it. And it's kind of focused mostly towards board relevant topics for the critical care boards. But let's see what we can get out of this. So the first slide, Harris, since you're so close to me and standing up already, do you want to describe to us what this is?
That's a pressure count curve with a flow count curve on the bottom forward, the constant curve, constant slope.
Okay. So what mode of ventilation is this?
This would be pressure control.
Yeah.
Actually, it's going to be volume control. That's because of the constant flow. You have a volume control.
Yeah, that's one way of looking at it. The best way, I think, is to look at the pressure scalar. So these are scalars over time. And if you have an ascending pressure scalar, that's kind of specific to volume control mode of ventilation. So this is a pretty decent breath on a passively ventilated patient on volume control ventilation. Okay, so let's look at another breath. I don't know everyone that walked in, but let's go with Lionel, since I know you. Can you say what's wrong with this breath, or if it's correct, is it right?
Compared to the previous breath, it's not the slope of the inspiratory side. It's a little bit more bent. I'll say it's not as straight. So I would assume that the inspiratory part of it was cut short. So it has like steep.
Are you speaking about the flow down here, or the?
Yeah.
You're talking about this, the steep?
Yeah.
Oh, okay. Okay. So this curve is describing something called the stress index. Now, this is very specific to a volume-controlled method of ventilation, and what you can do is as the previous curve showed a nice straight slope. Lionel is correct to mention that this slope was what the term he used was bendy. It was pretty sloped, and if you draw that same line that you had before, you can see the slope is a little bigger, so it's higher, it's greater than what this slope was. And so when you have a slope higher than the flat slope you'd expect with volume control, you can assume that this lung is being over-distended. As you can see, the pressure increases drastically at this end of the curve, meaning that you're probably exposing this lung to barotrauma and volutrauma. So that's a stress index known as greater than 1 and overinflation. And the solution to that, because this is a volume-controlled mode of ventilation, decrease the tidal volume. All right, so look at this one. Ryan, what do you think is going on with this one? You can your espresso. Oh, there's chocolate and candy if anyone wants. There's chocolate and candy.
So
Tic Tacs.
Well, this is sort of the inverse of Plato's curve.
Yeah, exactly.
I'm trying to think. That one I could kind of figure out. So you're getting sort of like a increase in pressure without, I would guess, adequate inflation. So
yeah, I mean, you're not given the tidal volume.
No, you're right. But I mean, just based on the way the pressure curve is
acting at like the start of it.
Yeah.
Like it's basically just you're adding pressure.
So just compare it to the same way we did it for the previous one. This is volume controlled method of ventilation, and compare it to the slope of this, which is 1. The slope of this line is less than 1, right? So the other one we said was overextended.
Underinflating.
Yeah,
like
you're underinflating. So what would be the clinical? Yeah, exactly. The clinical situation would be a very decreased compliant circuit. So mostly like our ARDS patients can look like this. The solution to this probably would be to increase the tidal volume. Yes, yeah, so this is a stress index less than 1, and the solution is to increase the tidal volume. Okay, so these are just the 3 curves overlying, just so you can see all 3 of them. I've seen this one on a mix or a seek question, like included in here. And so I think this guy in this journal in 2013 looked at it in I think about 100 patients over the course of 5 years, and saw that it may be better to use volume control and ventilate to a stress index versus just solely a plateau pressure, because they didn't really correlate completely, but it hasn't been like validated or randomized or explored any further yet. So that's just one option you have. I guess the harm of that is that you can theoretically expose the patients to greater than 6 or even 8 cc's per kilogram per skip lungs, but that may just be what the patient needs. Okay, so Gargi.
Playing away?
No. Which one of these waveforms is the pressure support waveform?
You mean like which row?
Yeah, so the columns are each one mode of ventilation, and the pressure, flow, and volume scalars are listed there.
First 2. So it's either A or D. Probably D.
Okay. Anyone else want to throw in a guess? Anyone confident or has an idea or wants to start a discussion on this?
It's a pressure assistance.
A pressure support, yeah, pressure support. Okay. So Rashmi helped me make these questions. So everything she says is with a grain of salt. She may be messing with all of you, or she may be giving the correct answer. I don't know. So okay. So it's C. We have to explore why. So you missed the first part, Gargi, but basically the pressure scalar, if you have an ascending pressure scalar like this, then it kind of is specific for a volume control mode of ventilation for the most part, especially the patient's breathing passively. So this is volume control. And this is the ICP waveform. So I just threw that in there just to like mess with people. But then the difference is between these two. So pressure control can look exactly like pressure support, and sometimes the patient's like breathing very equally every breath. They'll look exactly the same. The way you can tell the difference if the patient, I mean, obviously you'll see that there's a trigger, but then sometimes the trigger, they might trigger this breath and they might trigger these breaths as well, right? But the difference between pressure support and pressure control is that pressure support is flow cycle, meaning that it will give you a specific amount of flow, and then it will terminate your breath right when that flow is reached. So you can see right here, the flow is terminated, and you immediately go to the expiratory phase. Right here, you can see in pressure control, there, it hits the baseline and it plateaus right there while your I time is still going, and then you reach your expiratory phase. So that would be a subtle difference you can use to differentiate pressure control and pressure support. Okay, what is the problem here? I'm running out of people to pick on. Rashmi already knows this. Michael. What is the problem with this scalar? Or if anyone else at any time wants to jump in at any of the other off-campus institutions or sites, please feel free to do so. Autopeep. Who's that? Oh, who was that answered?
Weiler.
Weiler, okay. Weiler, you're all of the Weiler. So it's not. Autopeep would have flow. Usually I use flow. Would have flow that doesn't reach the zero. But in this case, last graph, not enough inspiratory time.
You're losing something. You're losing flow somewhere. You're losing volume somewhere.
Yeah, exactly. Yeah, good.
Air leak, whether it be your cup is down.
Yeah. So the main point for this curve is that, the flow is actually reaching the zero line, so there's no auto peep here. You might have been looking at this. Leak is correct. Harris had said it first, so let's not give you credit. But there's a leak, obviously, right here. And this is a really quick way.
Leak is somewhere else.
Yeah. But it's pretty easier. It's a lot easier to pick up on the volume scalar than it is like looking at the VTI and the VTE to determine and subtracting every breath and hoping you catch it at the right time. But you can visually pick it up right here really quickly, and you can also estimate it and watch it go down when you inflate the balloon or you fix the leak problem or you put in the chest tube. I don't know. You can watch it go down. And you can, or if you have a patient with a trach and you can set them up and see if the leak goes away, you can just watch this, and it's a lot easier than counting numbers and calculating percentages. Okay. Oh, this is a good one. So what is the problem here?
It's like they're almost taking two breaths. Why are there two things on the pressure?
Okay, yeah, so this is weird. It's not the usual that we've seen before, and it's not something that we're really used to seeing. But why is it like that? Any takers?
Like they're inspiring. That's like
Yeah, exactly, right? Yeah. So it's not exactly breath stacking. It almost is, but it's more so that the patient is just not happy with the flow. And what we call that is flow starvation. So what you see here in the pressure cycle, what Gargi pointed out, it looks weird, looks like they're taking two breaths, is that actually they're sucking in here, so this is showing it's showing a more negative pressure than you're expecting. So you have like this dipped out effect. And then on the flow, you can see the positive flow going in. Now, you can say that this kind of looks like over distended volume controlled breath like we looked at earlier. However, you have to look at the flow curve or the flow scalar to know that the patient's actually getting a ton of flow here at the specific time where you have a scooped out appearance. So it's not an over distended volume curve, it's actually flow starvation. And it's a pretty common problem in a patient that's like sedated and not happy with your low tidal volume strategy. Good. So let's talk about pressure volume loops. Since you walked in, where does the volume go on the pressure volume loop?
What do you mean, like X, Y axis?
Yeah.
Y axis?
Okay, good. Yeah, I didn't know. It took me a while to figure that out. Volume goes on the Y-axis. Pressure goes on the X-axis. Okay. So for the next question, I want everybody in their head to picture what a spontaneous breath would look like on this axis. I'll give you maybe like 10 seconds. Hey, Vitas. All right, so everyone has their picture in their mind. Is this what you imagined? Yeah, so the spontaneous breath is completely different than a ventilator breath on a pressure volume loop. So which side of these is the inspiratory side, left or right? Left, yeah, so you can see as my awesome arrows show. The blue is the inspiratory side, and the red is the expiratory side. I'm bad with colors. Those are the colors that I think they are. So the curve will go like this on the ventilator scale or on the ventilator loop. So let's look at the next one. So this would be a passive ventilator breath, the one we're more familiar with, which we see on the ventilator most of the time, is inspiratory and then expiratory breath. Okay, what's coming next? Is this normal, abnormal, or why? Anybody, it's fair game. Abnormal, okay, why?
You shouldn't level off in the volume that you're receiving relative to the pressure. This is...
Somebody said COPD. Is this COPD? Yeah, exactly, yeah. So if you see, this requires quite a bit of pressure to get a change in volume, right? So when you're talking about changes in pressure and changes in volume, what are we talking about? What was that?
Like compliance?
Yeah, compliance, right? Perfect. So there's decreased compliance in the circuit because, as we all know, the compliance equation is volume over pressure. For a large amount of pressure change, you're getting a little amount of volume change, so you have very low compliance. So this is a low compliance circuit like ARDS, like the ones that we're most usually managing in the medical ICUs. Okay, so is this abnormal? And if it is, what's wrong with it? Anybody? I think everybody needs to have one piece of candy right now, or they fall asleep. Oh, I didn't catch that. What did it say? Yeah, great. Oh, man. The respiratory department is killing it, by the way. Exactly, yeah. Over-distension. How do we know this is over-distension? Well, part of this curve, so I'm doing the breath. This is the inspiratory breath, right? And you can see right here how the curve starts to level off. When it levels off like this, that means like you're getting no volume for whatever pressure you're expanding. So the way to look at this is there's 2 points on here. There's the lower and upper inflection point. So this is the lower point. This is the upper point. And not all the time will you see both points. Most of the times, I mean, you shouldn't see this point, because this means you're overextending the lung, or you're over-distending it. And then you have a lower inflection point. What that represents is theoretically the point where you should probably have your PEEP set to, because right here you want to make sure you don't have atelectotrauma. This is the point where you're getting slapping shut of the airways on expiration. It's just slapping shut. So if you set your PEEP here, this is the optimal recruitment zone. Over here is where you have over-distension. So you should probably decrease your tidal volume, go down on your peak pressure or something like that. And I didn't see much literature on this, but there was a study by this guy in critical care in this year, in 11 lambs, where he actually looked at the distension of their lungs after using a lower and upper inflection point strategy versus just using zero of PEEP. And he saw that hysteresis was what was really difficult. Was really a big problem in the patients with zero PEEP. It took them a long time to get their alveoli open as compared to the patients who had a higher PEEP setting according to their lower inflection point. So if you're ever questioning what to set the PEEP at, this may be one strategy. Okay, what's wrong with this one? Or is it normal? What was that? Michael?
You're getting a lot of volume for a very small number.
Yeah, so what would you describe that as? It's almost it's the other way around. Very high compliance, right?
Oh, yeah, sure.
So for a change in pressure, you have an incredible change in volume. And you would see that in a patient with COPD. You see the COPD long pressure volume curve can look like this. Pressure volume loop can look like this. Okay, so what's happening on this curve or this loop? I've run out of people at Moses to pick on for the most part that I know. Somebody at Weiler, can you describe this pressure volume loop?
Sure.
Wow.
Is this non-compliant?
Well, the non-compliant pressure volume loop was this one.
Oh, crap.
And this one. The increased compliant loop was this one.
Oh.
I'd have to say this is somewhat of a normal compliant,
Okay.
but there's something weird or different about it. What's different about it? You already know all the answers. You can do the next one.
No.
Starting pressure.
Excuse me? No, if I hear driving pressure one more time today, done. It's not a thing. It hasn't been validated. It's just a word that people throw around to sound cool. Yeah, respiratory department with the answer key. Yeah, so if you look right here, this negative, so by the way, if you remember from the previous slide, this point right here is the PEEP setting. So your breath will start at the level of PEEP that you put it at. And this negative pressure infliction is actually, so this is the inspiratory limb, negative pressure inflection is actually the beginning of a patient-triggered breath. So the ventilator will sense that negative inflection and then give this flow or whatever burr pressure to just like, to give the patient the breath. So that fishtail you'll see in a patient that triggers a breath versus the previous ones which were passive breaths. Okay, what do we have? Ooh, what is the most common cause of dysynchrony? It's getting interesting now. Which one? Oh, not in the medical ICU at Moses. There's no lack of sedation in the medical ICU at Moses, I'll say that much. So, yeah, which one of these? Yeah, it wasn't going to be that easy. Which one of these is the most common form of dysynchrony? We have a taker for B.
Yeah.
I didn't even put the letters up. How did you know which one was B? We have a takers for B. Anybody else want to be bold and not choose B? Erica? You have a white coat with your name on it. Sorry, it's just
You know my name. I think B.
okay.
Why not A or C?
Yeah, right. We see. Yeah, so.
We see C.
Yeah. We never see C because our therapists are very good at suctioning the patients, and we never see C. But the common misconception that this, what would we identify this as? Yeah, like double triggering. The patient's just not happy with the low tidal volume and wants another breath and is getting greedy and gets a double trigger. It's a common misconception that this is actually the most common cause of dysynchrony, but it's not. The most common cause is actually A, which is called inadequate triggering. So this one, just to go over the other ones first, this one is either just like increased secretions in the tubing, or sometimes in some patients could also just be cardiac oscillations, but for this one it's quite fast. Or water in the tubing, in that little like tubing that's at the hanging off the bed. Sometimes it just like reverberates. I don't know, how often do those get changed? I actually don't know. The tubing. PRN. Oh, okay, yeah. So if you notice this, then you might just need to change the tubing. And sometimes this can actually cause enough of a trigger to trigger a breath, just like it's doing in this. This one again is flow starvation, where you see this dip associated with the increased flow. So just looking at this one, it's zoomed in a little bit. You can see that now you have a negative pressure deflection associated with the increased flow, which signifies that this patient is trying to take a breath here and here, but is not getting a breath. And that's probably because the patient is auto-peeping a little bit. And to overcome that, you can just change the trigger thresholds to be a little bit more negative. Sometimes that gets kind of dangerous. People get scared of doing that because the patient just like might just keep getting very tachypneic and then auto-peep even more. Or there's thought that you can just do early deep sedation and paralysis. But if you look at your patients more carefully, you put your hand on the patient's chest when you're looking at the ventilator, sometimes you'll actually notice that this is actually present a lot. And now that once I learned about this and I looked at it and I learned that this was the most common one, I started looking at the vents more frequently. And this is very, very, very common, more common than double stacking. Okay, what seems to be the problem here? Okay, so for this one, you just have to spend a little bit of time. Don't like shout anything out, but just focus in, especially on the flow tracing, and just be very, like, take 10 seconds, just look at it very carefully, make sure you see everything slowly.
What?
No, I just wanted to mess with you guys. Nobody got freaked out. That sucks. I thought everyone was going to freak out. I couldn't find a scary picture.
Maybe if you had like noise with it.
I should have had noise, you're right. Okay, so this is a real tracing, so. Yeah, it's like really, really, really hard to like know exactly what's going on because you kind of want to figure out what kind of mode of ventilation it is, but it's like difficult. So I will give you that. So this is any of the automated modes of ventilation that we have. I mean, so like this is not what we're used to seeing on PRVC, right? Because that's the one we use here. I'll give you that the tidal volumes for this patient are probably no, I can't give you that. I can't give you that. I should have given you numbers, but let's say this is, I'll give you a number. Let's say this is right here, this number is 10. So this is 10 centimeters of water.
This means you're flow.
What was that?
So this means that you're flow limited and actually you can increase your flow to actually obtain the pressure that you want.
Wait, say that one more time?
You know enough results for the patient.
I don't know.
That's like very, very, very close. Very, very close. You just have to get one more step further.
One more step.
Yeah, because the real problem, if you understand the real problem here, and this is very specific, this problem is very specific to PRVC, VC plus, TAV. It's the only main problem with this mode of ventilation, is that you end up with this. And I can describe the patient to you. He's gasping for breaths. And he's awake.
So you're terminating your breath too early.
This is terminating the breath too early. Yeah, so like what is PRVC, right? Like PRVC, so basically it's pressure control, right? However, what the machine is doing is it's kind of guessing. It's shooting some breaths at you, it's shooting some volumes at you, and it's guessing what kind of compliance your circuit has. And it's not guessing by looking at the patient and seeing how much the patient is participating in the breath. It's guessing by sensing the numbers that it's getting from reading what the pressure is, what the compliance is. So if you have a patient that's awake and is like taking a nice big breath like this negative pressure inflection here, the ventilator is going to sense that it's a very highly compliant circuit. The patient does not need much support to get tidal volumes, because it's sensing a low pressure right there. So it's not going to give the patient pressure. However, this patient is like an ARDS and is struggling to breathe, is just awake. So it's incorrectly giving lower pressure, just not the flows, it's giving lower pressure, not enough pressure to the patient to support the breath. So this is like the problem with PRVC and VC plus and whatever PAV is, which I learned yesterday, I guess. But this is the main problem with that mode of ventilation, is that sometimes patients will get triaged to this form of pressure control, which is like not enough for the patient. And you can see them visibly being uncomfortable. And if you see the patients, like, you'll start to notice it more often, because it actually is very frequent. And a lot of times we go to the bedside and we see the number, the peak pressure is 13. We're like, yes, we are doing great with our ARDS. The peak pressure is 13. But it's really 13 because the patient's taking the whole breath. So it's the patient's negative pressure is contributing to the decrease, and the plateau might actually be 30, but the patient's not sedated and paralyzed, so you shouldn't be interpreting that 13 peak as a true peak. Okay. I'm scared, but so yeah, so it's kind of like a flow starvation of a PRVC mode of ventilation. So you guys were not happy with my scary picture. Okay, what seems to be the problem here? I think there's only like two more. So what seems to be the problem here? And Rashmi, you're now fair game to do questions because you don't know the last two. And like, please disregard my tracings that seem to escape time continuum and go backwards. Yeah, like it does this thing where it just goes backwards in time or it goes forward.
This one you actually have the inspiration too quickly, and that's why the extra pressure going up there.
Inspiration too quickly?
I think.
I will to freeze my eye time.
Yeah. So this is the patient at the end of inspiration is actively expiring. And you can tell on the flow loop that hits 0, and then you see this before, if you time these together, I should have put a line here, but if you time these together, before the breath, the inspiratory breath terminates, you see the patient take a deep, sharp flow down going form of expiration before the inspiratory time is even over. And that's why you sense this positive deflection here. So this is active expiration. It's another form of desynchrony. On a pressure-controlled mode of ventilation, you can decrease the eye time, and it might help. It should help. And yeah, you can see them up here, these little peaks. It's a sharp down. You can see it better here, sharp down. expiration before the inspiratory time is even over.
So you're saying you would actually increase that?
It would decrease eye time. You want to get rid of this
Because
part of
you
the
won't
pressure
stop
control curve.
exhaling before the eye time finishes, right?
Yeah. Is that what you said? I'm sorry.
I don't remember.
Okay. Yeah, so you want to get rid of this part of the curve. It's like just too much, too long. It's the opposite of what we're used to seeing because usually our patients want more because of our low tidal volumes, but this may be present later in the hospital stay at some point. We just never see them because we send them to the floor. I think it's the last one. And please bear with me because I'm like not an expert in this at all, and I wanted to talk to Dr. Gong about this, but I didn't get to bump into her. Let's just work through it together. There's no scary pictures, don't worry. Super appropriate for treatment of ARDS. Good question. If Lawrence is logged in, you are not allowed to answer. A. Okay. It's one of the three, but it's okay. All right. So for the esophageal pressure, I'm going to try my best to explain this. So for the esophageal pressure, what happens is, and this was studied in EP Vent, which was, I think 3 years ago, 4 years ago, and it just showed that you have a really awesome increase in oxygenation with esophageal balloon probe, esophageal pressure probe guided management of your PEEP. There's two things you can do with it in these ARDS patients that's more important. You can help decide what your true plateau pressure is, right? Because we're worried that our patients with ARDS have all this chest wall compliance problems and all this like obesity and abdominal distension have a falsely elevated falsely elevated plateau pressure, and we're thinking that maybe if you get rid of what's outside the lungs and figure out what's actually in the lungs, we can help guide our ventilator management better. And this would pertain to either your tidal volumes if you're using volume control or your peak pressures if you're using pressure control. So you can actually use the esophageal pressure at the end of inspiration, which is right here, to help guide what your true plateau pressure is. So if you subtract your esophageal pressure from your plateau pressure, you'll get your true alveolar distension plateau pressure, and you can guide your you can guide your alveolar distension to that. Oh, I think right. That's one thing. But the more important thing, I think, is, and that's optimal ventilation strategies. The other thing you can do is to prevent atelectotrauma. So this is another thing you can use to help guide what your PEEP setting is going to be. And your PEEP, again, is to help prevent atelectotrauma. So where you want to set your PEEP is at the level of whatever pressure is closing down your alveoli at the end of expiration, right? Like your PEEP is keep alveoli open at the end of expiration. So at the end of expiration, which is right about here, you want to see what your esophageal pressure is, and let's say this number is 7 or 10. You want to set your PEEP to something at that or slightly above that. So you want to make sure your PEEP, which is this right here, should be kind of above what your esophageal pressure is at the end of expiration. And in A, you can see the esophageal pressure is way up here, but the PEEP is actually what looks like probably lower than that. And so you're getting really bad airway collapse at the end of expiration. You're going to get atelectotrauma, and you're going to expose yourself to ALI. In B, this is just very over PEEPed. You're just going to get barotrauma because your PEEP is way too high. You can see that your esophageal pressure is negative for the most part, and your PEEP is set at way too high for that. So you don't need this much PEEP. So you're overusing PEEP here. And in this one, you have a pretty appropriate PEEP setting, which is just above the esophageal pressure tracing line at the end of expiration. So C would be the most appropriate. And you can see these lines here which help guide you. Okay. And this is the study, and it showed that you have a really like about a 90 millimeters of PaO2 higher in the EP esophageal pressure guided arm. And this is probably going to be something that we're going to have to eventually learn. It's probably going to be able to be validated by the EP Vent 2 study that we did here. I sense that this is going to be on our board exam. Highly sense that. Okay, any questions? Questions? Okay, thank you. Oh, you're unmuted, just to clarify.